Welcome to SNU Hospital Cath Lab. I'm Hyo-Soo Kim from SNU Hospital. First operator today is Dr. Jung Kyu Han and Dr. Hee-Jin Lee and Dr. Yong-Gu Lee and many other staffs are standing. Okay, Dr. would you please your case?
네, 슬라이드 보여주세요. So today's case is, next slide. Today's case is a 77-year-old male patient. He suffered chest discomfort during exercise, and he was referred for PCI due to heavy calcification on CT angiogram to our hospital. And the previous CT angiogram shows a diffuse 70% stenosis with heavy calcification through the medial AD. And actually, it was performed 2025, not 24. And there's intermediate region and proximal circumflex artery. Next. And he had dyslipidemia, and kidney function is good. GFR is higher than 90. Next. And so today's plan is IVL. Next. Chest page shows normal X-ray, and electrocardiogram shows normal findings. Next. The echocardiography shows the preserved ejection fraction 70%, and there's no regional wall motion abnormality. Next. So CT angiogram, you can see heavy calcification actually from the left main through to the medial AD, and the stenosis is higher than 70% on CT, and I will show you the angiogram. Next. There's intermediate region, the circumflex artery, and calcium score is higher than 1900s. Next. So about 1 week ago, we performed the angiogram, and you can see the diffuse coronary artery atherosclerosis with stenosis. And there's eccentric plaque at the distal left main artery and diffuse region through the proximal medial AD with the heavy calcification. And you can appreciate the calcium on the still cut on the right screen. Next. And this is a cranial view showing the diffuse region, and there's, you can see distal left main eccentric plaque with heavy calcification, and you can also appreciate the calcium on the still cut on the right side of the screen. Next. And here, aerial view shows also eccentric plaque at the distal left main with the stenosis. Next. And diffuse region was observed in the RCA, but it's not an indication for the PCI, I think. Next. So we performed the angiogram, IVUS, and normal segment at the point A shows the vessel size is 3.0 millimeters. And the point B, you can see the MLA. The MLA is 2.0. And point C, there's a heavy calcification. The arc is greater than 270 degree, and length is at least 5 millimeters. And point D, you can see the calcified plaque, and then lumen area is 5.9. So we are going to place a stent from the distal left main to the medial AD after IVL. Next.
Okay, this is the case for the first live demonstration in our hospital. We prepared 2 discussion points. The first point is usage of IVUS or OCT in evaluating calcified lesion. There are pro and con between 2 modalities. Last week, we used IVUS and decided ablative therapy is required to assess the lesion. Today, we would like to show you OCT. The second issue is choosing IVL versus rotablator. Plus, here is algorithm for treatment of calcified coronary lesion based on IVUS calcium score versus OCT calcium score. A little bit different. First, on the right side, IVUS calcium score is composed of 4 points. First is circumferential calcium, 360 degrees. Second, calcium more than 270 degrees plus length more than 5 millimeters. Third, vessel diameter less than 3.5 millimeter. Fourth, calcified nodule. In this case, we observe second, third, and fourth. On the left side, based on OCT, we also scoring the system. The all point is 4. First, calcium arch more than 180, 2 points. Length more than 5, 1 point. Thickness more than 0.5, 1 point. Thus, osteocalcium score should be 4 to do ablative therapy, such as IVL versus RA. Plus, here is the actual example to scoring based on IVUS and OCT. On the upper panel, in the IVUS examination, we can see circumferential calcium 306 degrees, or arc more than 270, diameter less than 3.5, length more than 5, and presence of calcified nodule. That constitute all 4 points. Lower panel, we can see a length more than 5 millimeter in OCT, arc more than 180, thickness more than 0.5 millimeter, and all point is 4. In this case, we calculate IVUS score, that was a 3. Today, we calculate OCT score, that was 4. Thus, this patient has enough calcified plaque to be treated with ablative therapy. Plus, which therapy? This is algorithm to select IVL versus rotablator. The most important rough indication is shown here. Diffuse extensive calcification prefers IVL, while critical stenotic calcification prefers rotablator. On the right side, there are 4 merits for rotablator. First, facilitating device delivery in balloon inaccessible lesions. Second, gradual superficial calcium ablation. Third, predictable advancement and stepwise ablation. Fourth, small ablated tissue fragments with low risk of large embolization. On the left side, there are many merits for IVL. First, no requirement for a specialized wire. Second, calcium modification at low balloon pressure. Third, deep calcium modification. Fourth, low risk of distal embolization. And finally, able to protect side branch with second wire. Next, thus our plan today for patients having diffuse extensive calcification, we chose IVL rather than rotablator, C2 plus model, delivering 120 pulses. Target calcified segment is long, 55 or 60 millimeter. Balloon length is 12 millimeter multiplied by 6. Thus, we treat 6 segments stepwise. For each segment, we are going to deliver 20 pulses from mid-LAD to distal left main. Mid-LAD is small, thus we use low pressure. Distal left main, big enough, thus we use nominal pressure 4 or 5. It is a kind of issue to choose IVL balloon size for treating such a long calcified lesions because we would like to use just one balloon. It is very expensive. In this case, 3.0 or 3.5, our consensus is 3.0 because 3.5 is too big for treating mid-LAD. On the right side, B segment shows mid-LAD lesion. MLD is 1.4 by 1.8. Thus, it is too small to accommodate 3.5 balloon. On the D is really a target, important target, distal left main calcified nodule. MLD is 1.8 by 3.7. Thus, we expect 3.0 balloon may well contact a vessel wall and deliver shock. Can you see the OCT taken today?
Yes.
Okay.
OCT 좀 보여주세요.
We took OCT just several minutes ago.
큰 화면. 요게 보여야 돼, 요게. 네, 그렇게.
Okay, this is pullback image, and then next we would like to show you several frozen images that emphasize how severe the calcification in this vessel. Okay, this is just the left main. Then can you see the step frozen image from distally?
지금 보여주고 있습니다.
Here's distal LAD. Okay, mid LAD. We can see the big calcium chunk in mid LAD as pointed by B. The thickness is about 1.3 millimeter. Bigger than 0.5 millimeter. The circle is already about 200 degrees. Next. Here we can see also calcium nodule on the 7 o'clock. Next. On 8 o'clock, the node thickness is 1.34 plus. On the 5 o'clock, plus. Here we can see really 270 degrees calcium nodule plus calcium nodule on the 9 o'clock plus. This is the left main. We can see a big calcium chunk, calcium nodule on the 7 o'clock. The thickness is 1.5 millimeter. Thus, we guess osteocalcium score would be about full 4 point. Thus, it is rational to treat this lesion with ablative measure.
Okay. So,
Okay, please ask the question and discuss.
Yeah.
Then we are going to do procedure.
okay, go ahead. This is already 12 minutes passed since we started.
조금 더
Actually, I like to tell the foreign doctors. I like to say that this recently, this year, the IVL has introduced in Korea about March, and that the experience of IVL in Korea is primitive. This is at the stage of early experience. Many of you are expert in IVL, and can I invite some comments? Okay, go ahead.
Yeah, we've had IVL for about 6 years now, and obviously it's been a great tool and very useful. I guess it'd be interesting to hear what your experience is. When we first got it, we used it a lot because it's very easy to use and very safe to use. But actually what we found is over time we're using it less because actually we found that we can actually modify a lot of this disease with alone. And I think there were some good lessons from the Eclipse trial. So the Eclipse trial, showed heavily calcified arteries, and actually in the balloon-only arm, they achieved big MSAs. The MSAs were, I think it was 6 or 7. Heavy calcification on the angiogram doesn't need for IVL, and it's great that they did the intervascular imaging here. Both IVUS and OCT, and obviously OCT has some
조금 더 빼야
advantages
되니까
in terms
나중에
of thickness.
디스텔레프니까 확실히 커버해요.
One other comment is that now we use the rule of threes rather than the rule of 5 for OCT. So this work has been modified. So we're really looking at 270 degrees of calcium, the minimum thickness of 300 microns, or 360 degrees of calcium, and that was shown to be a lot more predictive than the rule of 5. So it'll be interesting to see. I must admit, in this case, I would have been tempted to try with the balloon first and see if I got good expansion. But it's very reasonable to use IVL.
Actually, in the presentation, there was no option about the cutting balloon, right? So we have to compare the high pressure NC balloon, cutting balloon, ablation, and IVL. It's a fair to compare. So CAPS trial you mentioned is the comparison between the cutting balloon and NC balloon, and cutting balloon was better.
하면 되지 않을까?
Okay, and prediction.
심하지 않으면은
So, what do you think?
좀
The current limitation with IVL is that the balloon is 12 millimeters in length. So here you have 6 segments, and you're going to deliver 20 pulses each. That's assuming the balloon will profile. So it's going to be minimum 120 pulses, right? It is cumbersome. If you think about atherectomy, you make a couple of passes, let's say with a 1.5, it should go pretty smoothly. It's going to be very feasible because it's not tortuous, it's not angulated. So that's something that I would have considered, just because. I personally use orbital just because it allows you to go from low speed to high speed without having to swap. But given the results of the CLIPS trial, one makes you wonder if that paradigm should shift. But in that trial, it was only for people that are eligible with both balloon and orbital. Or if the balloon did not cross, then they would not be enrolled in the trial.
Maybe can I make some comments as well? Chairman? Currently in Japan, rotablator and orbital atherectomy and IVL, 3 calcium modification devices are available. And the template is very different. So, rotablator is, for example, this case is, we must take care of the distal embolization because diffuse embolization. And compared with rotablator, IVL is almost no risk of distal embolization. That is a very good advantage. However, balloon profile is not so small, so deliverability, crossability is not so good. And so, indication and region is very different, I think.
What's your choice for this lesion?
This case is, I think maybe distal part is IVL balloon is, I'm afraid delivery is possible or not. And for example, left main is deep calcium is detected, but that part is IVL is probably not effective because opposite side is very healthy. So no effective.
IVL has a very similar effect on the eccentric versus insultant calcium. The data says, I don't know. The data says the same
but
effect
in actual practice, modification to eccentric deep calcium to create damage inside the calcium is very difficult. I think that is my honest impression of IVL usage.
Chair, can I make some comments as well?
Personally, actually, we can examine the lesion with IVUS or OCT. I prefer not to use rotablation. The passage of the stent is very easy. So the MLA in this case is 2.0 square millimeter. 1.5 burr is the area is 1.75. So 1.5 burr is smaller than the 2.0 MLA in this lesion. So rotablation is not working here, I think.
I agree.
Cutting balloon is actually my first choice for this case. So Dr. Kim? Actually, the preparation of a balloon is very important because this is very weak balloon, low pressure balloon. So air preparation is critical. And have you tried the 2 or 3 times of negative air preparation for this lesion? So we can see some air in the distal part of the balloon.
Yeah, I'm very sorry. Dr. Lee told me she repeated 5 times.
Yeah, more than 5 times.
Really?
Yeah, more than 5 times.
Yeah.
We didn't expect this.
This is an important learning point. Okay. So you may prep the balloon and you may get rid of all the air, but when you do IVL, it generates air. So often you will have to re-prep the balloon halfway between.
Okay.
It's very important because once you have an air bubble like this, it's less than 50% effective. You really reduce the effectiveness of the IVL when you have an air bubble like this. So at this stage, it's really important to re-prep the balloon to take the air out. I think the second thing that we've learned is when these long diffuse lesions, rather than just because you've got so many areas to try and shock, rather than just balloon the whole length. This is where something like stent boost works very well, because by doing stent boost you can see the areas of heavy calcification, or you can see the nodular calcification. And really, if you want to get the maximum effect, you can actually see the emitter. Let
me remind you that the pressure wave, IVL generates pressure wave pressure wave goes very effectively through the fluid, not the air. If there is air between the balloon and the lesion, this is not effective.
아닙니다. 지금은 그냥
So actually, the IVL is recently introduced in Korea, and we are exploring, and we are learning stage of IVL, and
퍼딜하고 나오는
give a lot of the learning points for this case.
디플레이션.
The other thing about IVL is that 20 pulses a lot of time doesn't work. I just share some of the experience since we started in 2019. In the year we started, we had 1.9% of cases. This year, we crossed 5.6%. And a lot of the cases are combination cases nowadays, about a quarter with rotoablation and IVL. So we use a smaller rotoablation and then all OAS followed by IVL. It shouldn't redistribute 20 pulses each. You should concentrate more pulses. 20 pulses is too few for bad lesions. The other thing is that you're trying to get IVL to work in concentric, thick, and calcium nodule. It works quite differently. I think in those cases where it's concentric calcification, it works quite well. And it's actually quite nice to test it with a balloon, like cutting balloon. If it doesn't expand, more pulses of IVL in that segment will help a lot. In this case, in the distal left main, when the lumen is 5.9, I think IVL has minimal effect in the eccentric calcium nodule in the location. So I think IVL can't do everything, but it's definitely helped the ease of doing work, and therefore the use case will increase gradually, I think, in Korea as well. Thanks.
So actually, calcific nodule is the most difficult lesion to treat, and even with the rotoablation, we found that this is very difficult to treat calcific nodule even with the IVL. So what's any experience for the treatment calcific nodule with IVL rotoablation, which is complete or still way to go? No?
Recently, there was a publication in the JACC intervention. It's saying they're telling us that for the calcium, less than 180 degrees in the circumference, then the calcium could be cracked in only 50% of cases.
Professor Han, this is Cha from Korea University Annam Hospital. You're now doing the NC balloon. Could you
30 NC balloon
consideration about the OCT first before the NC balloon? Because we already the shock wave, so we can see the OCT image more directly to the effect by the question. How about it?
This is NC balloon. What is the size?
30.
30. The previous IVL balloon is also 3.0, right?
3.0.
We try to reduce the contrast dye used in OCT to minimize the OCT examination. So anyway, we have to do examination of OCT after NC ballooning. 12?
네.
Okay.
And we found
then
that
we can show you OCT finding.
네, 여기서 하이 프레셔 가겠습니다. 20까지 맞춰서.
Actually, we found a very enlarged lumen even after the IVL low pressure ballooning. Actually, this I think it's very effective.
네, 가겠습니다.
Okay.
천천히 가요. 4까지.
So maybe just a comment on the balloon size. I mean, the key thing about IVL is you have to have apposition distance. So in this case, we would tend to oversize. So we would have taken 3.5 because we're concerned about opposed to the proximal vessel. The reality is that you, in the distal vessel where it's 3.0, you can inflate the IVL balloon to 2 atmospheres. Okay. So, and you're not going to cause damage. So when you have that discrepancy, generally we tend to oversize, use low pressure to make sure we have apposition at the proximal vessel.
The size is related to a lumen diameter, not the vessel size.
But in the left main.
Left main, consider left main. It's better to use 3.5. Better to oversize the IVL balloon.
NG 한번 괜찮나?
네.
NG 한번 줄까?
NG 주겠습니다.
Well, I'd like to discuss this notion about rationing the shock, because this is a C2+, so you have 120. And Professor Kim plan to give 20 shocks per segment throughout the whole lesion. But we know that sometimes with a concentric, maybe just 10 shock, the calcium will break. On the other hand, the calcium nodule sometimes needs much more shocks to actually fracture that nodule. So I'd like to ask comments on this rationing of the shocks along the whole
more shocks for calcium nodule.
Would you focus your shock on specific spots, or you just ration the whole segment with an even distribution of shocks?
Right.
We deliver the differential number of shocks depending on the different segment. As Dr. Kao mentioned, some segments require more shock, whereas the remaining segment does not require such a high 20 shock. But we treated different number of shock depending on the characteristics and severity of calcium.
I think also this is time sensitive, but anytime I see the soft portion of the wire, and that's where the distal tip of the ibis is, I cringe a little. So I think just being a little bit cautious with that is important.
저 정도 커버가 됐다고, 오케이. So we did OCT examination. 자, OCT 한번 디스플레이 한번 줘볼까요?
코 레지스트레이션 하는데 시간이 걸려서 그렇습니다.
Okay. Actually, we are expecting to find some calcium fracture. Can you show us? For your information, actually, we can find several calcium fracture after IVL, but final MSA is not related to the number of the fracture. So there is even OCT is insensitive to find the fracture. Did you find the fracture here?
Yeah, 너덜너덜. You can see 너덜너덜 morphology. Okay, just once again. As we can see the fracture on the left side. Here also, here. So this is the results of combination of shock wave plus moderate degree of NC balloon. I think this status is acceptable for stent implantation.
Yeah, I agree.
And with LAD, we use 30 Zions.
시너지입니다.
Synergy, Boston Scientific. And proximal, we are going to use 3.5 with pod proximal optimization confined to left main up to 4.
338. 3에 38. 그러니까 3에 38. 할까요? 네.
Okay, actually, you remember the roller coaster epic trial that shows the compared excimer laser, IVL, and rotablation. The IVL is comparable to rotablation. The difference is that the failure time, the dilatation failure is more frequently noted in the rotablation. The crossing failure, device crossing failure is more often noted in the IVL. So in this lesion, IVL is completed, we expect a very nice stent expansion.
We finalized the procedure. So you'd like to show you angiography that we take. Okay, this is the final angiogram that you see. So then we implanted a stent. This study 30 by 32 synergy.
Pressure?
We can see that there is a indentation.
At the pressure of? What pressure was
pressure
it?
12 plus.
12 atmosphere. Okay.
Then we increase the pressure up to 18.
Still some indentation.
Still some indentation plus. another high pressure plus here angio plus we did 30 NC balloon up to 22, 24 plus. Then we implant the second stent. Due to the length issue, we chose Osiro 35 by 40 to cover the upper part of left main body, plus with highest pressure, plus here is angio after implantation of second valve, plus. Then we did proximal optimization using 4 by 8 balloon, plus. Okay, this is implantation of 2 stents and adjunctive ballooning, plus. Then we did OCT examination and found there is still on the expansion, expanded but not satisfactory to our criteria. That's we did NC balloon up to 25. This is a final angio. Plus, then we did OCT. Can you see the final OCT?
Yeah, not yet. Okay, we can see that. Yeah, please go ahead.
Yeah, we can see the longitudinal analysis. We can see the really well expanded valve stent. There is no red dot through mid LAD to proximal LAD.
Yeah.
Good opposition.
Yeah, elliptical but well expanded. In calcified lesion, we can see a lot of elliptical expansion. But if lumen is okay, it's okay, right? Okay.
All the struts are well opposed, except for the left main bifurcation area.
What was the MSA?
The least area of MSA is 4.52 square millimeters at this mid LAD, as shown here. No, more distally. Oh, there, okay. 4.52 square millimeter. That was the narrowest point. Then we'd like to compare this finding with the initial OCT finding. Then we can see the fracture and displacement of calcium plaque and calcium nodule. Here is baseline
at this
OCT
point.
finding. We can see really many calcific nodules surrounding the lumen. Here, big calcium.
Yeah, I can see that the MSA was noted on the MLA before treatment. The MSA, MLA before treatment, the same site.
Same site?
Yeah.
뭔가 저 빨간색 있는데 그게
20 근처일 것 같은데 거기 찍어놓은 데 좀 보이세요.
Okay, here.
1.3.
MLA 1.33. 1.3 square millimeter change to 4.5.
더 디스탈. 거기.
Okay, left main distal. Here's left main distal. We can see big calcium chunk on the 7 o'clock. 약간 조금 더 잘 보이. Oh, okay. Then remember this image. Just return to the final OCT finding. Final 한번 가실 거예요. Minimal MLA was 1.3, changed to 4.5. Here is the distal left main final image. we can see some shadow on the 7 o'clock, but not well demarcated because of the destruction. Once again, this is the left main. Here's this the left main.
So the nodule is actually opposite to the circumflex ostium, right?
Probably.
Because
Anyway, stent is well expanded. I think stent is well expanded in the left main, right?
Yeah.
You are not satisfied with that?
Yes, we are satisfied. There is some ectatic portion in a certain part of circumference. And that point, the stent strut is separated from the ectatic wall, but that is not a problem.
Yeah. The focal malar position, but it's clinically not important.
It's
Okay, can we
clinically
see
not
the final
important
angio-
until you come back, right? And until you
Angio-
come back, because the problem is if you have the area of malapposition, two things can
Angio-
happen when you come
Pakaji.
back, right? The guide catheter can damage the stent, or you can wire under the stent if you have to do a further intervention. So, certainly I would pot in this area to try and, at low pressure, to try and get apposition. This guy has got disease in his circumflex, quite a lot of disease, not flow limiting maybe, but moderate disease. And there's certainly a chance of need further intervention. So I think we should always be thinking about the left main, okay, not only is it going to cause a problem, but, what's going to happen when we come back. And I think if you leave that malapose...
You think we need the part for the left main. But many studies show that the malar position is not related to clinical outcome. And the calcific lesion, we can see a lot of malar position actually.
But I agree with Scott because it's not about the result of this time, but the second time intervention. Because the circumflex may need intervention in the future. So I think to bring the best position in the left main is important. And also I will pay attention at the circumflex ostium. Like I mentioned earlier, maybe the nodule is opposite to the ostium, so this is favorable. But I will try to make the polygonal area as perfect as possible because I may need to go to the circumflex next time.
So what do you think, Dr. Kim? You like to further inflation balloon?
To clear the polygon, we have to do a final kissing ballooning. But under angiography as well as physiologic examination, circ flow is no problem. Thus, I don't think to change the morphology of main vessel stent frame by final kissing balloon.
I think kissing balloon is probably not necessary, but a part in the left main, and also make sure that the ostium of the circumflex is clean. I mean, the nodule is really opposite to the circumflex ostium. If we can confirm that, I think the procedure is done very perfectly.
So how, 저 OCT에서 조금 더 circumflex 그게 보이게끔 한번 볼까요? Bifurcate. Here,
You see
so
the
you
circumflex
can
is
say
coming at 1
circumflex
o'clock.
is 1 o'clock.
Yeah.
Calcium nodule is 7 o'clock, exactly opposite direction.
So this
Calcium
is
nodule is
favorable.
always at the opposite side of
lateral
big
side.
branch. Yeah, this is there is a necrotic
I mean,
core.
in this area, we don't have to oppose the stent strut into the circumflex. No need.
Yeah.
I think this is favorable. But then the left main shaft itself, the proximal
Can
edge
you
of the
can you show us the proximal portion of the left main shaft on the OCT?
yeah, the proximal edge of the
More
stent.
proximally,
The most proximal portion,
proximally, more.
as far as you can go.
Proximal. Left main ostium
Here,
쪽으로 바랍니다.
you're mentioning this one. Proximal end of the left main stent.
So,
Still, there is some mouth
This
position.
one.
right?
but we're not necessarily seeing the full
Okay.
extent of that because we are not actually seeing the proximal
Okay.
edge of the stent.
Yeah.
There may be more
Proximal.
malapposition, more proximal.
Yeah,
So
maybe it should be opposed.
do you want us to do a post ballooning to make the several strut at the proximal edge of the stent?
Yeah, I think that will be better because next time you don't worry about wiring under the
물론
struts.
4.5로 할까요?
Actually, I'm still not sure about the clinical impact of this menopause strut, but as you comment mentioned that in the second procedure, it will be very difficult to wire inside of a stent, so better to oppose the stent, left main. I agree.
아까 똑같이 하면 되겠네.
8.
With 5
없으면 10짜리로.
5A.
Yes, I think 5 is necessary to get more better position.
Okay.
But just low pressure, right? Because all we're
We are
trying
going to do post ballooning with 40 by 10 semi-compliant balloon, not NC. We did 3 times post ballooning for left main using 40 by 8 NC balloon with very high pressure.
But they're small. I think
MLD is about 4.2 millimeter. We would like to use semi-compliant balloon.
Which size?
Spider.
What will be the size of the balloon?
40
40
by 10.
maybe
노란 게 낫잖아.
the channels saying that's too small.
Yes, I agree. Yes, 4.0 is
Yeah,
too small
4.5
to
or
get our position.
many recommend the 5.0.
At least 5.0.
Yeah, 5.0
And the high pressure is
or
not
position.
necessary.
Pressure
So
얼마지?
bigger size is better to get a position.
그리고
Okay.
테스트. approximate만 보면 돼. 좀 더 빼가지고.
We have 4 minutes, and we'd like to say goodbye to Dr. Kim at this moment, and we come back to go back to NC University. Dr. Kim. Dr. Kim.
20. Yeah.
Very nice
Can
demonstration
you
of
see
IVL.
the post-Bologna angio?
Can you summarize your case?
Summarize.
We need to move to Yonsei University.
Extensive calcification from distal left main to mid LAD can be easily treated with just one balloon of IVL.
Okay.
30.
Yeah. Still, I'm wondering that the cutting balloon, it would be, what would be the result of cutting balloon? We are exploring all the cases in Korea, and we'll have a more experience next year.
I really, I was enthusiastic for cutting balloon about 10 years ago.
Yeah.
Now I try to forget its presence because always disappointing.
Yeah, I'll ask you next year again. Okay, nice job. Thank you very much for the nice case.
Thank you.